At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live. Hello and welcome. My name is Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I have the privilege of being your host for this and most episodes of GLI Live. On occasion, we have a guest host. And so this episode and this month, we're going to be doing a series on books that we love, books that are really essential to this space of healthcare and liver health and patient engagement, all the things that I love. I get a lot of questions about my bookshelf here, and if I've actually read all the books, if they're just props. I have read all of these books. And how do I choose books? Well, sometimes it's just books that wonderful friends of mine have written that happen to be transformative to healthcare and that I really want to make sure everybody reads. So this book, Rebel Health, is such a book, and it will, if I can move the presidential pen from a bill signing and the GLI, knickknacks and things like that, this will go on the shelf of incredible books by people I happen to know and love. And with me today is Susanna Fox, one of those people I know and love and admire, who is the author of this new book, Rebel Health. Hello, Susanna.
Hello, I'm so glad to be here.
Thank you. So you were kind enough before the book was out into the world to give a preview to our patients and caregivers and families at our Advanced Advocacy Academy last fall. But since then, the book has actually been published and is out and it's in people's hands. And hopefully they've scribbled as many notes as I have. And so maybe tell people about the book and then the feedback that you've gotten so far to it.
Thank you so much for having me. Rebel Health, Field Guide to the Patient-Led Revolution in Medical Care, is my way of introducing two powerful groups of people to each other. One group are the people with whom I've spent the most time in my career. That is patients, survivors, caregivers who I've interviewed or spent time in their communities, talking to them about how they use technology and other resources to transform their own lives and innovate in healthcare, often at the edges, often on the frontier of science, because they have to. The other powerful group of people are the people with whom I've become more recently acquainted, and that is what I call the C-suite of healthcare, people who work at the highest levels of government, who work at the level of the CEO, CFO of health systems, payers, all the people who frankly control most of the resources in healthcare, who don't yet all know how powerful and innovative the patients and survivors and caregivers are. I wrote this book literally as a field guide, as a way to say, here are the people that you'll meet.
Mm-hmm.
You join this revolution, whether you join it from the front lines, from the bedside, or whether you join it because you want to tap into this energy and make it a competitive advantage for your company or for your agency.
So sometimes in bookstores, I see they want to file this under fiction because surely people, patients couldn't possibly have anything to offer. We're not really, hacking into CGMs and remaking diabetes devices or changing policy at the boards of hospitals. You just made us up. So this is a book of pure fiction. Right.
Well, so it's funny. So people will say, when I start to talk about the concept of the overall concept of peer-to-peer healthcare, the power that comes from people connecting to each other online, people will have a couple different reactions. Some people will say, oh, I know exactly what you're talking about. You're talking about Facebook.
Mhm.
Or another group of people will say, oh, I know what you're talking about. You're talking about AA. And I will say, yes, and yes, I'm talking about Facebook. And I'm talking about the ways that people are able to, as you say, hack into their own medical devices and free the data. I'm talking about people who are able to, yes, gather together in groups and affect policy at the national level. Um, because this is both grassroots and a very individual and personal revolution, but it's also a national revolution.
Mhm.
And if people aren't aware of it, that's just because you haven't been looking at the underground movement that's been happening.
Right. So why did we have to I'll just out myself as part of the underground movement. Why did we have to create an underground movement? Why did we have to create rebel forces? Why were healthcare, if healthcare systems writ large, not just hospitals but the whole sort of ecosystem, not designed for the people who use them, who are they designed for?
Well, they're designed for the mainstream. They're designed for people who don't fall off the conveyor belt of healthcare. And that actually turns out to include fewer and fewer people these
Right.
days. When I started looking at the history of radical health movements in the United States, I actually went back about 100 years.
Mm-hmm.
And I looked at why is it that people have felt the need to self-organize and turn to each other. One reason is that their needs are not being met by
Mm-hmm.
mainstream healthcare, and the other major reason is that they are invisible. Their needs are not visible to
Mm-hmm.
mainstream healthcare. That's a nice way of putting that they're not
Mm-hmm.
visible. Often it's because mainstream healthcare isn't looking. And
Right.
so, for example, so radical health movements often come from people who are marginalized because of discrimination, because of, let's just say it, because of segregation, because they are shut out of the medical system. They often self-organize to find ways to first help each other and get more resources by drawing attention to the fact that they need help and that actually they found some solutions here. And those are the same patterns, the patterns that I saw, for example, um, in the way that in the Jim Crow South, Black
Mm-hmm.
nurses were able to self-organize medical teams to help
Mm-hmm.
people, the same way that Alcoholics Anonymous was founded in the 1930s. There's a radical health movement that emerges in every decade of the 20th century, and then it accelerated because of the internet.
Mm-hmm.
And the other reason why a Rebel Health Alliance will form is when they actually are visible to the mainstream
Mm-hmm.
healthcare system. But patients and survivors and caregivers themselves have ideas about how to do it better.
Mm-hmm.
And that is equally powerful. And I talk about both of those kinds of groups in the book.
Absolutely. You create a really useful framework that I want everybody to go out and buy the book and to open it up and crack it open to this matrix. Because as we, particularly here at the Global Liver Institute, when I was looking through that matrix, I was like, this is a perfect way to describe where we are as a field and as a community. We are invisible primarily, and GLI has certainly been trying to make liver health more visible in everything we do, and our needs are woefully unmet. We are underdiagnosed, we are undertreated, we are not connected to care. There's such huge stigma that people don't even uh, bother to give us treatments that do exist. We have cures out that people that don't get to us. And then we have pipelines of drugs that we hope to get approved, but it's been a very hard road. And so uniformly across the board, no matter what type of liver disease you look at, we are still invisible in most ways, and our needs are unmet, and they are myriad. So that framework that you gave is so helpful for me to explain it was a sad, cold night when, and I swept the tear away, but I'm like, okay, but everybody has to start somewhere. And that's where we're starting.
Well, it has to start with seeing the problem. And
Right.
and if we don't have a way to visualize the true picture of suffering,
Right.
then we can't construct a healthcare system that takes care of everyone. And a part of that matrix that I want to double down on in this conversation is to say the horizontal axis is needs not met on one side and needs met on the other.
Right.
And the key here is that people themselves get to decide if their needs are met.
Right.
It's not actually up to a doctor who says, well, I've given you a prescription.
Right.
Well, why aren't your needs met? It's up to the person to say, well, all my questions weren't answered, and so I'm not going to fill the prescription, which is a loss for all of us.
Absolutely.
And so that's a really key point that I wanted to underline. That what I tried to do with the book was listen closely to patients and caregivers and survivors, and listen to the language that they use, and then try to reflect that.
Absolutely. I think that is so important because so many times there are all the questions in between we're given this will take you 18 months to recover. Great. What happens in those 18 months? No. And that's where you have to come to a patient advocacy group to talk to other patients. You're like, well, in the first week, you're going to feel like this. The second week, you're going to, and we value time differently and what happens in that time, because that's 18 months of our lives. It's not just sort of 18 hypothetical, conceptual months, but it's 18 months of our lives where we have to know, well, when I be able to work or take care of my family or, walk or go back to the gym, and how will I feel? And it's also a loss of a lot of data that doesn't have a place to return to EHRs and to create truly learning health systems of all the, sort of tricks that patients figure out to do well or to overcome. And there's no official repository for all that wealth of information in most cases. And so other patients coming down the road don't benefit from that to the extent that they could and should. And so there would be more needs met if that information was connected.
I totally agree. We are leaving half the team on the bench by
Right.
not including patients and survivors and caregivers in this learning health system. The fact that there generally is not an intake valve for the kind of data that you're talking about of, well, it could be 18 months for in general, but could we shorten that? What are the quality of those months? All of that information you can only get if you are lucky enough to stumble on a peer-to-peer group.
Right.
Or if, gosh, I mean, so let me ask you this. Do you know of any clinicians who, that you've talked to who are recommending joining a peer group for liver disease?
We are, yes, now that we've sort of gone physician to physician and created champions, created people who will recommend and are working to create, peer support in their communities or with their hospitals. And at first it started with, let's sort of meet their needs first as researchers. Let's get you a special program of research excellence. And then maybe after that, once we have that settled, then can we work with you on a support group? And so, we've created that dialogue. And now that we have community-based organizations that are part of our group, we are sort of, going directly to different institutions and saying, we are here, we are real, we have things in different languages, we will please give, and helping to stay top of mind for them and to be part of their workflow and to demonstrate how we can solve problems for both them and their patients through our ambassadors programs. And so, we're gently, but we're there and doing the work, but it's not.
And improving outcomes. It's just, it's one of those things that when we talk about centers of excellence and we talk about the ways that connecting as a patient or a caregiver, you want to connect with a center of excellence,
Right.
Because you know you're going to get the best care. Let's start to recognize that there are centers of excellence in the patient communities,
Right.
Because that's where there's a lot of information and a lot of learning that's just like lying fallow. It's not being used. So I'm so glad to hear that you guys are starting to be recognized as partners in that.
Absolutely. One of the other things that this book is really phenomenally helpful for patients and patient advocates trying to find a place and find their identity once they realize, I'm like, something's wrong here. I've gone through an experience and it doesn't feel right, but I don't quite know what to do next. You've created these archetypes of people so you can sort of help understand yourself better. And why advocacy might be for you. So maybe talk a little bit about the different archetypes that you've identified.
Thank you. So when I started writing the book, I was looking at first at a pipeline of innovation, and then I realized it's not really a pipeline because different people take different actions depending on the problem that they need to solve. People also take different actions and step into their power in different ways. Not only depending on the problem they're trying to solve, but who they are, what skills do they bring to their patient advocacy. So I'll go through the 4 types. The first type that I talk about are seekers. Seekers are people who are not getting the answers that they want, the information that they need, and they decide to go out on the hunt. And what really characterizes seekers is that they do not give up. And my message to everyone is, if you find yourself lying on the floor next to the conveyor belt of healthcare, you need to either become or recruit a seeker. And this is really important in speaking to the patient population. You don't have to become all of these. You can look around your network and say, is your best friend a seeker type? Do you have a niece who's a nursing student who could do this work for you? So a seeker will go and find out. That's characterizing that type. The second type are networkers. Networkers are the type of people who are joiners. They're people who have never met a stranger, whether it's in their faith community, whether it's in the neighborhood, whether it's online. They're the types who are going to pool resources. They're going to, if they find out something great, they're going to tell everybody they know about it. They are networkers who pool resources. The third group are solvers. Solvers are the type of people who, if something isn't working, they can't wait to take it apart and put it back together again better, whether that's an assistive device, a medical device, or actually a system. Solvers can attack a system and solve that problem in creative ways. The fourth group are champions. Champions are people who have access to resources that frankly patient-led teams don't yet generally have access to. The first and most obvious one is funding. Champions can give a patient-led team access to money that can help them scale their idea. Champions can also have access to labs and manufacturing facilities. They also often have access to regulatory guidance. Champions can be people who shine a spotlight. It could be a journalist, it could be a podcaster who shines a spotlight on a patient-led team and allows them to get the attention that they need to scale their idea. Those are the 4 types: seeker, networker, solver, and champion.
Absolutely. I definitely identify with the solver and the champion most. And I had a wonderful experience. It was wonderful because I was able to say thank you and give some acknowledgement. I was sitting at a meeting with someone who is in industry, and as on the stage during the course of the conference when they were talking about different ideas, whether it was from community health workers, or there was a lot of really fabulous ideas for like what worked in healthcare. And having known this person a very long time throughout their career in industry, I was like, I remember when you funded the very first, program for like national community health workers. I remember when you funded prizes to identify, patients who were doing, remarkable things. And I was a judge on that first. And I remember the trajectory that changed of that contest it gave for that patient innovation. I remember when the act on the idea of having a patient embedded, and paid for them to be full time for a period of time within their company. And so that example of champion, I guess I recently read your book. Actually, I had just come from your your book signing and I have to play it, so it's very fresh. But it was just a perfect example of a champion, of somebody had used the resources of his very large company to support and fund and really push forward these patient led innovations, so that they could become reality and become part of healthcare. And we need sort of more of those.
Yeah, we need to lift up these stories where people are solving problems, whether it's
Right.
patient survivors and caregivers solving problems, or whether it's healthcare leaders. What I hope is that that his colleagues that recognize that this wasn't just a feel-good exercise.
Right.
This is actually a competitive advantage
Mm-hmm.
for this company, because they now have an intake valve for
Right.
ideas from this underground revolution
Mm-hmm.
that their competitors don't have access to yet.
Right.
And so if we can find mission alignment
Mm-hmm.
between the patient-led revolution
Right.
and the bottom line of
Right.
whether it's a government agency and the mission alignment that we see there, or a company, that's when we're really going to convince a lot more people to join this revolution.
Right. None are so blind as they who will not see.
Mm.
So, it's interesting when it stays a competitive advantage. He's been doing it for years, out in the open, and nobody else has said, we could do the same thing too. It's been astounding as how they let them have that competitive advantage and don't take it on, and don't scale it. Or when we, as patients who are connected, say, over here they do this and this has been very successful. They're like, oh, can we do something different? I was like, don't worry about being different. You could be successful too. We'll build you something different if you want to be different. But why don't we be successful first in something that is proven to work, and then we'll get you something flashy and different and everything. It's been amusing. Keeps consultants in business. But there are a lot of things, my husband, Dr. Dennis Cryer, reminded me that when we met 19 years ago at the National Minority Quality Forum, he was there in his then position as head of external medical affairs at Bristol Myers Squibb, presenting on work he had been doing in Texas and San Diego with federally qualified health centers and other community groups to reduce health disparities. And I looked at him. Would you like to write this proposal? Like, where are those slides? We could do the same thing today. That was 19 years ago. And maybe I didn't listen closely enough because I was too, busy being dazzled by the man who would a few months later become my husband. But I was like, no, I did not remember that's what you were talking about. And where are those slides? Because we could do those today. We haven't made that much progress. That what you did then has been so, put out of business that, oh no, we've just so solved healthcare disparities in Texas and California that we don't need any of that.
Well, I'll add to that. I'll say joining the patient-led revolution is like buying Apple stock.
Yeah.
Yes, you should have done it 19 years ago, but it's still time.
It's still time. Exactly. It's still time. It's still the trend. It's still, there's still work to do as we.
I should hasten to say that this is not an endorsement for Apple stock. I own no Apple stock.
Neither one of us own any. I don't own any individual stocks because yes, we keep ourselves available for government service and other things like that. But it's not a trend. I think, is what early on they was like, okay, patient engagement, that's great. That'll be the trend. What next? What next year? What should it be? And I think health equity is also seen as, okay, that's a good trend. We should do that this year.
When in fact it's foundational.
Right. I'm like, I've been Black all 53 years, and I will continue. In my expectation is that my understanding of this is that I will continue to be Black for however long God sets me upon this earth. And so my interest in resolving health disparities and ensuring that everyone has access to high quality healthcare is not going away. And so it will still be my focus next year.
Absolutely.
And
we need to design a healthcare system that serves everyone.
Yes.
Because we are all in this together.
Right. We talk in liver health about, well, who needs to think about their liver? I'm like, well, everyone has a liver. So everyone needs to think about their liver health. How about that? That's my market. Those are my people. That's my remit, to make sure everyone
if you are human
is healthy. Exactly. If you are human. Now, there are some of us who maybe didn't have a liver for about an hour or two as it sat outside before the transplant and stuff. I'll give you that. There's that little bit exception. So if you want to be like in the comments being like, well, some people have, I'm like, okay, you in the comments. But everybody's eventually, for most 99% of the time, you're going to have a liver, and you're going to need to know how to take care of it. And so that means everybody should understand how the whole system needs to work for everyone. We have collaborated in different ways on different parts of some of the same things. And I wanted to talk about one of them, the fabulous people who were involved in the long COVID work, the patients who said, you're not answering my questions, I want to do this. And then the wonderful Helen Bernstein and the Council of Medical Specialty Society. So the physician groups who reached out to say, we want to partner with you so that this is not just ignored. It doesn't just go away in the annals of history, that we want to elevate this and help you get PCORI funding for this and access to people like Donna and Susanna Fox and lift this up. So can you talk a little bit about that collaboration? Because I think if there's hope for the future, it looks like that generation and that partnership and the publications and all the wonderful things that they've done.
Thank you. The Patient-Led Research Collaborative for Long COVID is an example of a couple things. One, it's an example of you can't let a crisis go to waste. We have learned so much from the COVID-19 pandemic. And one of the things that we learned, that I think we learned globally, is in a fast-moving crisis, we need to listen to everyone. Yeah. That everyone was experiencing this at the same time. And patients who noticed that their illness was not following what was being publicly talked about as the course of illness, they were not getting better after 2 weeks. They were experiencing neurological issues. They were experiencing GI issues. They were experiencing so many things that were not being described in any country. So there was a small group of patients who, by the way, were suffering from long COVID, what we now know is this post-viral illness. They banded together to do a survey to try to capture what are the real symptoms of this emerging illness. What I love about them also is that they learned from the past. They quickly looked at disability, the disability movement. They looked also at the ME/CFS work that had been done, another post-viral illness, and they built on those foundations. Their publication, based on their international survey, actually was cited in The Lancet. It got the attention of Francis Collins, then the director of the National Institutes of Health. They got attention from the CDC, the WHO. By the way, while they were sick in bed, they were able to collect this data and get national attention. They're an example of a group of people who stepped into their power. They stepped into their power as seekers who said, we're not finding the information that we need. Let's go and find out. They stepped into their power as solvers,
Mm-hmm.
using Slack and Google Docs,
Mm-hmm.
whatever tools they could find to build this evidence base. And they then the story of how we got hooked up with Helen Burston is a great one, because it's, again, don't let an opportunity go to waste, where the Council of Medical Specialty Societies had a series of webinars talking about data registries around COVID-19. And I messaged Helen and said, hey, I noticed you don't have any patients
Mm-hmm.
who are talking about data registries. Did you know that there are, at that time, I counted 5 to 8 patient registries
Mm-hmm.
that were, essentially patients gathering data on their own. And she said, awesome, you step in and lead a webinar.
Mm-hmm.
And I invited 2 members of the Patient-Led Research Collaborative to join me, along with 2 other experts in the field. And that's how the groups got connected. And what I often tell people is, do work that calls to you,
Right.
whether you are getting paid for it or not,
Mm-hmm.
because goodness will come from it.
Right.
So in that sense, it was a perfect encapsulation of Rebel Health, where we had this powerful group of patients together with a powerful group of clinician leaders, who, and I acted as the ambassador between them.
Right.
But once they were connected, it was this alchemy that created these scorecards that maybe we can link it in the show notes.
Yes.
That will help other resource organizations follow the recipe that was created by the Patient-Led Research Collaborative to create real partnership between patients and researchers.
I think that, like your book has done in, encapsulating stories that would otherwise be lost, about the people and the actions that were taken that, lead to the expectations that we have today. Their scorecards and their publications, because they did such wide-ranging interviews, and they talked to so many of us, and as the public member of the CMSS, and rooting them on and helping with that, really felt like that I could sort of pour out my knowledge, and it would be kept in a place and not lost to history, and applied somewhere. And we can point to these things and recommend these things to people who want to know, well, how do you engage patients? What does it look like when you do it well? Well, now we have some for you to read, so that you don't have to actually believe us. You can read about it. And I think that is hugely important as this movement matures. I tell my team that it is such a privilege of age, of many things, to have been able to see the arc of this movement change from, I don't know why a patient would even want their data, to, I'm so sorry, Mrs. Cryer, that we won't have your, biopsy results in your, in your portal for, 24 hours. I'm like, well, that's okay. That's all right. That having seen that shift, I just smile. And so for people who are working on issues today so passionately and get discouraged, I give them, this book and that scorecard, and just say, the arc of history bends towards justice, even in healthcare. And so we will prevail here too.
Hear, hear.
Thank you, Susanna Fox, for everything, and for today.
Thank you so much for having me.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.